Hello, everybody. We are here at the Global Specialty Lens Symposium at the Eaglet booth, where we're going to be talking about their Eaglet Eye Surface Profiler. My name is Craig Norman, and we really want to welcome here today Dr. Barry Leonard. How are you today?
Hey, Craig, thanks.
Who's going to talk to us a little bit about this whole process of using the Eye Surface Profiler. You're in practice in California.
Correct.
And actively fitting large diameter scleral contact lenses. Can you talk to us a little bit about how this tool works for you and how you utilize it in the practice?
Sure. We've done things for a lot of years the same way. And we'd fit a large diameter lens and we'd say, here we got to vault the cornea and really land on the sclera, and that's where the physiology is, the comfort is, and that. And we sort of guessed. And we all thought we were guessing pretty well, and we'd look at a lens and go, yeah, it looks okay, it doesn't look okay, and we'd make some refinements. But with the technology we have available now, in taking a profilometry measurement of the sclera, even out to 20 millimeters, we now know really what's going on out there, we know the shape, and we can do a lot better job.
So in your practice, I'm referred in as a patient. I have some kind of condition that you think for keratoconus, failure in contact lenses. Right. And your staff, when your staff is first working me up, is this an integral part of that process?
Correct. Once I've examined you, I've looked at your basic topography, and I've determined that you're a patient for a large diameter lens. I mean, there's still places we use small diameter lenses. For me, if you look at that delta K and it's over 250, 300 microns, we're going to go to a large diameter lens. So I say, Greg, here, this is what we need for you to get you that comfort, vision, physiology that we need. So at that point, we're going to go and take you over to the scleral lens profiler, the Eaglet, to measure you. We use it, in addition, to the scleral lenses. It also can be a lot of other specialty lenses because it's giving us information about the HVID, our pupil sizes, a lot of other information. So we're even doing multifocals or others. It is a big help also.
Okay, and I think that's a key element because we're focusing on the ability of the surface profiler to look at a large area, as you said, up to 20 millimeters across the anterior surface. But all the action is around the pupil and the HVID, and to be able to gather that information must be helpful also.
Yes. Again, in the past, I thought I was pretty good with a ruler, and I realize now with parallax and other things, my HVID was off, my pupil size was off, and that affects a lot of our vision.
Right. So this is a screen of a capture. Can you tell us what we're looking at here?
So we're going to see, in the center is your cornea, and that's going to be off of elevation-based thing. And we'll even find there, I have a great topographer in my office, but as we all know, in a lot of highly irregular corneas, I don't even get the whole cornea.
Of course.
I maybe get 30, 40% of it. And now all of a sudden I'm getting the whole cornea, which can be a help.
Yep.
But also now, as you see here, we're out in the sclera. And what the colors are, similar to what we all know with our topographers, are telling us the height and depth of that. These blue are sort of the lakes, those deep lakes, very steep, and these red parts flatter. And we then can gather all that information. It's going to give us more than we probably ever want to know.
Right.
But it's going to give us all the information that we need to know to fit accurately any large diameter lens.
Sure. So the coloration shows us the different elevation areas of the surface. And then, of course, here we can actually see what the shape of the eye is.
Correct. And I'm able to do that in any meridian right now. We're at the 180. I can take this line, spin it around, you will see that change and measure on those.
Do you typically do that to just get an overall idea of what's going on?
Correct. I will do that. There's also a 3D image that is really what we're trying to do. We're going to mold a lens right to that. The labs now, I can send this information and they can pretty much mold that lens exactly to fit like a saddle on a horse.
Right.
And really fit there, exactly.
So at that point, you've got this information, and then you're able to choose the initial diagnostic lens by a menu that lists the different products that are loaded already into the instrument, and then choose the diagnostic lens and have your staff put it in, or you put it in, and off you go.
Correct. So that first diagnostic lens is going to be it. No more of 2, 3 diagnostic lenses just to even get to that point.
Right.
And from that, we can now get our over refraction, and really we're ready to design the lens and get that first lens fit in over 50% of our patients using this
Right.
Eaglet technology
Right.
now.
So do you think it's more accurate than the typical fitting guide information that comes just from the manufacturer? You know, because they're kind of grossly just pointing you in a direction.
Correct.
But they don't have all of this information
Exactly.
that you do.
And it's been interesting working with the labs now, and over the last couple of years of using the profiler, they're now saying to me, hey doc, your lens fits are really different than everybody else. And we've noticed also that you're not reordering them, and that
Right.
it's working. And
Right.
why is that? And they're very interested, and now the Eaglet is working with the labs. As we know, we have over 30 lens designs loaded in. And the beauty is also, though, if you have a lab that's not in there, you can still take that information and use it. It's still going
Right.
to tell you how to design any lens.
Right.
You can do that. But
So for instance, you know, the laboratories can do so many things today with these lenses. Anything you can mathematically define, basically, they can make. So how about if there need to be a notch in a lens or something? What does this show us related to that?
right. So notches we've done in the past. Sometimes they work, sometimes they don't, and the biggest problem is they're never reproducible.
Right.
So now we can see, this is a good example, it's a patient with a large pinguecula. And whether it's a pinguecula, or maybe there's a shunt or a bleb, and you have an elevation that's not normally there, we can address that. So we get the fit, everything else we want. We know we're going to have different meridians and toricity, and now we have this large pinguecula, and we all know we're going to get compression. And labs now can design a vault or a channel to not compress
Right.
that area. And what the Eaglet will do, I can take my cursor, I can measure the height, the elevation, the depth, the width, everything I need to give to the lab,
Right.
and say, put this exactly there, and it's a big game changer.
And the location, correct?
Correct.
I mean, you know, if it's offset a little bit away from the 180 line, it can be very accurate, which is important if you're using toric peripheral curves and aligning the lens in such a way.
Exactly.
That information would be crucial.
Yeah, and we can usually hit those the first time.
Okay, that's excellent.
There you go.
So for our viewers, is there any little tips related to the use of the instrument or incorporating it into the practice you'd like to share?
It's the learning curve is very quick for myself and my staff. The Eaglet people come out to your office and train you as much as necessary. And after the first couple patients, it's fairly easy and quick to get good scans. We use fluorescein, it reflects off that, we get a good scan, and then we're ready to go. We found all kinds of tricks. How do you open up the lids real wide? We like to use little finger cots or a glove to get a little more grip.
Sure.
But it's very easy on the patients, easy on my staff, and we can get quick, fast things. What's real been interesting for me is finding, I've had patients that I'd fit old school way, and they did well. They'd come in and say, Doc, I'm here for my annual exam. My lenses are doing pretty good. And I say, hey, we got some new technology. Let's do this Eaglet scleral profiler on you. I tell them why, and all of a sudden now I've refit them different. And they go, hey Doc, my other lenses were good, but wow, these are really good. And you do see it much
That must be very
better.
gratifying.
It is.
And then, do you ever use this to show the patient what's going on? Of course, they won't know what they're looking at necessarily, except they look at it and go, this is very high tech.
Oh, yeah.
My other doctor never did this type of thing.
Exactly. It's a great practice builder. I show them this. I show them the standard one. I can go down here to the 3D image and move it around, and it's very impressive. And then they can understand the 3D image, especially. They understand, wow, he's going to just fit that
Right.
exactly on
Right.
there. And that. So
Right.
that part of it has been amazing to track patients.
Yeah.
To my
Like, I think it'd be helpful also for patients because, patients, let's say, have keratoconus, and they can't explain easily to their family why they just can't get glasses. The family's going, just go get glasses so you can see. But possibly by being able to educate the patient about the configuration of their eye would even help them to share it with their family about what's going on.
It is. It's a very good point, Craig.
Yeah.
It does help.
So, wow, that's excellent. I really thank you very much for joining us today and sharing some of your expertise. The Eaglet Eye Surface Profiler, obviously a very, very interesting piece of equipment. For those of you that are viewing this and have had the pleasure of listening to Dr. Barry Leonard, I think we've all learned a little bit more about how to use this excellent instrument. Thank you very much.